Let me get my participant list. All right, Dave, you can go first. Or Pat, whatever you want to.
What?
You can do number one. Everyone open up your JBLs if you can. Go to your quizzes or just read off the screen. Whatever you guys want to do. But if you want to write the answers down or you want to take the quizzes as we're doing them. All right, we'll take the highest grade, which everybody should be getting 2 free 100s right now. But we're going to go through it. All right. Pat, you can do number one.
All right, a conscious and alert 29-year-old female with a history of asthma complains of difficulty breathing that began just before her morning jog. The temperature outside is 40 degrees. On exam, you hear bilateral expiratory wheezing, and providing supplemental oxygen. You should C, determine if she has been prescribed a beta antagonist inhaler.
Yep, exactly. All right, because we're going to help her with her albuterol treatments if we have. Okay, good job. So one is what, C?
C.
Okay.
I'm sorry, what test is this?
It's the respiratory quiz. It's the chapter 16, I think.
Oh,
They were closed over the weekend because of when they were actually due, they were closed because of the
yeah,
the maintenance. So a couple people did them, I guess, this morning when the site came back up, but we're going to do them all together now. And then if anybody watches the video, they can have all the free answers and take a second test.
Okay, good.
All
Yeah,
right.
I can't make mine move for some reason.
Huh?
You're going to have to scroll the screens up.
I did.
Okay, there you go.
Yeah, no, you won't be able to make yours move if you're reading off of my screen.
Mhm.
All right, Carolina, you can go next.
Okay. Number 2. A pleural effusion is most accurately defined as. Oh shoot, I'm thinking B.
B, nope, so it's not collapsing of anything.
Wait, fluid accumulation outside the lung.
Yep.
That's
So
B.
number 2 is D.
Okay.
All right. Oh, this one's going to be a pain in the butt. All right, who's next on the list? Addie, go ahead and do number 3.
Okay. Albuterol is a generic name for, I believe it's the first one.
Ventolin?
Yeah, I think.
Yep.
Okay.
Yep. So albuterol is the generic name of Ventolin. All right.
Mhm.
Who's next? Bridget?
Alkalosis is a condition that occurs when, is it A?
Blood acidity is reduced by excessive breathing. No, that's acidosis. Low shallow breathing. No. There's acid. Yeah, it should be A. Yep. So blood acidity is reduced. All right. So alkalosis is when someone becomes more basic. All right. Or their pH is going to go up. And then acidosis is anytime someone is maintaining too much carbon. Okay. So anytime if you see it says carbon dioxide increases or acids accumulate in the bloodstream, that's acidosis.
So quick question.
Yep.
She said A, and that answer for me is D.
What do you mean?
Yeah, so A says slow, shallow breathing eliminates too much carbon dioxide. And then D.
Oh, because you're taking it on your quiz. You're actually taking your quiz?
Yeah.
Yeah. Okay. So, yeah, if you're doing your quiz, do whatever blood acidity is reduced by excessive breathing,
okay.
whatever,
So,
whichever option that is.
Mhm.
All right. When we print it out, it basically, this is the way it'll show up on my, like when I wrote it, this is the way that they're written. They
Okay.
just, they jumble them for when they do the quests. It's all randomized. All right, Gianna.
Hi.
Hello.
Okay.
Can you do 5 for me, please?
I can. An alert patient presents with a regular pattern of inhalation and exhalation and breath sounds that are clear and equal on both sides of the chest. These findings are consistent with adequate air exchange.
Yep. Yeah.
Yeah, nothing's going on.
Nope,
That's
nothing's
normal.
going on. That's a simple one. That's adequate
Cool.
air exchange, right?
Yeah, yes, it is.
Okay. Isabel, you want to go next?
Sure. Asthma is caused by a response of the what is it? Respiratory system?
Nope. So asthma is actually caused by the immune system. There is some sort of allergen or
I need a desk though.
irritant
Here, hold on.
that ends up causing the respiratory symptoms, but it's an actual immune response. Okay, so asthma is actually caused by the immune system. It's allergies or antigens or something like that, some sort of irritant. Joe, are you able to do one or no on your iPhone?
No.
No.
No. That was just
What
me.
was question 2?
Huh?
What was question 2? I was just pulling it up.
Question 2.
Yeah.
Which one's that? The pleural effusion?
Yeah.
So what is a pleural effusion? You tell me. And I'll tell you if you're right.
B.
Read it to me because our letters are going to be different.
Diffuse collapsing of the alveoli.
Alveoli? Nope. So that's something different. All right. The pleural effusion is any accumulation outside of the lung, like in between the two pleural layers. When the fluid gets out there,
Okay.
that's what a pleural effusion is. All right. Joe, you ready or no? Should I skip you and come back?
Yeah.
At the onset of acute asthma attack, patients commonly experience difficulty breathing and
I can kind of hear him.
respiratory wheezing.
Expiratory wheezing. Yeah. So expiratory wheezing and stridor are kind of the same.
Yeah.
But you'll hear more of the stridor because it's an upper airway, not a lower airway. And the wheezing happens in the lower airway. Okay. So for this one, it's more of a stridor. Let me turn my sound off. There we go. All right.
Wait,
Who's
so
next?
it was expiratory wheezing? I thought.
No, it's audible stridor.
That's what I thought. Okay. I'm like.
No, so the
very
wheezing
far
comes
away
from the bottom. Wheezing you're going to hear through the bronchioles and or the lower branches of the lungs. The stridor you're going to hear from the bronchus/trachea area. Okay, you're going to hear that from the top half. All right, which is where the asthma usually occurs. All right, Joanna, you want to do number 8?
Sure. Common signs and symptoms of acute hyperventilation syndrome include is it C?
Which one's B for you? Are you reading on my screen or are you taking your test?
I'm reading your screen. Is it C?
So unilateral paralysis and slurred speech? No, I don't think so.
Anxiety, dizziness.
Oh,
So
yeah, I
yeah.
meant the anxiety, dizziness, and severe.
Oh,
Yeah.
bradypnea? No. So what is bradypnea?
Yeah, it wouldn't be slurred speech.
Right? What is bradypnea?
Slow breathing.
Slow breathing, right? So if they're
Okay.
hyperventilating, right? If they're hyperventilating, what does hyperventilating mean?
Fast breathing.
Fast breathing, right? So so now what does tachypnea mean?
Fast breathing.
There you go.
Okay, got it. Thank you.
Okay. So tachypnea and tingling in the extremities. All right. This is why I try to help you guys with the medical terminology because you can literally figure it out just by knowing the words. All right, who's next? John? John, can you do number 9? Oh, I'll even put the answer up there for you. Hold on. Let's go down a little bit.
Yeah, I just can't say that word.
Dyspnea? Yeah, I can't say it very well either.
Dyspnea
There you go.
is most accurately defined as shortness of breath or difficulty breathing, D.
Shortness of breath or difficulty breathing. Yeah, whatever answer that is on your screen.
Oh,
All right. Or if you're just writing them down. Well, if you're taking your quiz, it's D. Okay.
yeah.
But like
yeah.
if you're looking at the screen, it's A. So
Okay.
that's why I'm letting people know whatever the shortness of breath or difficulty breathing one is. You guys, that's right. All right, who's next? Julian. Gonna do number 10 for me.
Harsh, high-pitched inspiratory sounds are characteristics of, is that a strider?
Yep.
Okay. Yeah, so that'd be D.
So Strider, yep.
Yeah.
All right, Kayla. Let's go ahead and do number 11.
Hyperventilation could be associated with all of the following except.
I'll get the answer off the screen, but
I didn't even see it.
for those of you paying attention. All right, so which one of those is gonna affect your breathing? We kind of haven't gone over it yet, but
You mean it isn't going to affect the breathing?
right. So all of those can cause hyperventilation except for one. One of them will cause the complete opposite, which is what it's asking. It's asking you what does not cause hyperventilation.
C.
Yes, the narcotic overdose. All right, narcotics cause respiratory failure. So narcotic overdose will not cause hyperventilation. If you overdose on aspirin, you can end up hyperventilating. High blood sugar, they're going to try to blow off the sugar, believe it or not. So they're going to start hyperventilating. And then respiratory infection is just going to lead to difficulty breathing, and people are going to try to start hyperventilating just to perfuse properly. So who's next? Lucy, go ahead and do number 12.
In order for efficient pulmonary gas exchange to occur, A, and oxygen and carbon dioxide must be able to freely diffuse across the alveolar capillary membrane.
Yes, very good. All right, if you're looking at the screen, it's D. Okay, if you're if you're taking your quiz, whichever one. I'm like, you said A, and I'm like, no, but then yeah, you're fine. Oxygen and carbon dioxide must be able to freely diffuse. Yes, sir.
I had a question on the last one.
Sure.
Didn't you just say Monday that you can give out as much aspirin as you wanted to somebody?
You can.
But then how would you overdose on it?
I mean, if we'd have to be talking like grams worth of aspirin.
So is that possible?
I mean, if someone went and took the whole aspirin bottle before you got there, then yeah, but.
Okay. That was just a question.
Oh, so an overdose of aspirin would be the answer to that?
No.
That's what I thought. Okay, that's why I thought, wait a minute. Okay, I thought it was narcotic. I was like, wait.
No, because I said on the other day when we were talking about like, if someone takes aspirin and you show up, you can give them more aspirin.
Uh-oh.
All right, so let's get back. Who was next? Where did we leave off? Larry, you can go ahead and do one. Hyperventilation. We did hyperventilation. There we go. We did that one.
Or he said to do the next test question. Do you have it pulled up?
Question 13.
Do you want me to read it and then you answer? Oh, okay. I'll just read the question. She said her screen is really blurry, so I'm just going to read it for her.
Okay.
In what area of the lungs does respiration occur? The alveoli, the bronchi, the capillaries, or the trachea? The alveoli?
Yeah.
That is her answer.
Yep, the alveoli is right. Okay. It's where all the gas exchange takes place. All right, Luca, go ahead and do number 14.
The two processes that occur during respiration are inspiration and expiration, ventilation and diffusion, diffusion and oxygenation, oxygenation and ventilation. I think A, inspiration and expiration.
Yep. So respiration is clinically just the inspiration and expiratory phase, right? Ventilation is the actual diffusion and oxygenation part of it. All right, so there's two separate phases. All right, Marissa.
When assessing for fluid collection in the lungs during auscultation for lung sounds, you should A, pay special attention to the exhalation phase because this is when you will likely hear rales or ronchi. B, start at the lower lung fields and determine at which level you start hearing clear breath sounds. C, note the presence of a high-pitched whistling sound, which is an indicator of fluid in the lungs. D, auscultate the posterior chest first and compare the apex of one lung to the base of the opposite lung. Is it B, start at the lower lung fields and determine at which level you start hearing clear breath sounds.
Yep. Yeah, so you want to know how far up the fluid is. That way we know how bad of a response they're having. So we start at the bottom and work our way up.
Interesting. I didn't know that.
Mark, you want to do 16? It's only if you hear fluid in the lungs. If they're clear, I mean, you don't have to worry about it. But like when you do the bottom, if you hear fluid, start working your way slowly back up so you hear where it stops.
So when listening for lung sounds, you should always start at the bottom?
No, I always start right at the top in the front, and then I go into the lower armpits, and then I check the back. I do a certain routine. But if you hear them in the lower in the back, like then start, go back and start working your way up because now they have fluid and you're looking. Sometimes you may hear fluid right at the top, and you're like, okay, you're full.
Okay.
Right? I mean, it just depends. Mark, go ahead and do 16.
16. All right.
Yeah.
When auscultating the lungs of a patient with respiratory distress, you hear adventitious sounds. This means that the patient has, well, it's probably A. I can see A, which is diminished breath sounds, B, normal breath sounds, C and D are off the screen, but it's probably diminished breath sounds or abnormal, actually.
Does that make a difference? Abnormal is better? Yeah. Adventitious. I don't even really understand what adventitious means.
It's a stupid word.
What are adventitious breath sounds, Mark?
It's a catch-all for all of those things. It's really just any abnormal breath sound.
Oh, for anything. I got you. Okay.
Oh, is that the orthopedic surgeon?
Yeah, talking about breath
Oh my God,
sounds.
hi.
I haven't used a stethoscope in 3 years.
Use a stethoscope. It doesn't matter. You still understand.
Yeah.
So is the answer abnormal?
Abnormal.
Yeah, anything abnormal. Yeah, you hear adventitious. What? Even I would look at that and be like, oh, yeah, I'd give you credit for any one of those 4 answers. Adventitious. What are you talking about? All right, Misha, go ahead and do the next one, 17.
When the level of arterial carbon dioxide rises above normal, respirations increase in rate and depth.
Yep, because you're going to try to start blowing off that carbon, right? Before you get acidotic. Okay, who's after Misha? Phil.
Oh, we're on 18, correct?
Yep, we're at 18.
Which of the following conditions would least likely to result in hypoxia? Severe anxiety.
Severe anxiety to result in hypoxia? Yeah, I'll go with anxiety. Anxiety will work. Miss Taylor.
Which of the following is most characteristic of adequate breathing? 24 breaths a minute with bilaterally equal breath sounds and pink skin.
That is true. The answer is just peeking up off the bottom of the screen, but Yeah, so it's a little fast for normal. We say 12 to 20, right? But it's equal breath sounds and pink skin.
Yeah.
Okay, so it's most characteristic. All right, they're not worried about the rate. They're saying what is the best breathing patterns out of the 4 options there. Right, so 20 was shallow movement of the chest wall and pallor, which means they're, not very pink. Kind of getting grayish is not good. Right, if it's irregular and they're blue, no matter how much you're breathing, you're not good. Right, if you're using retractions and clammy and you're hyperventilating, again, that's also not good. So good job. All right, back to the top of the list because I don't think Nicole has a microphone. Nicole wants to try to answer. Nicole, are you there? Nope. All right, we'll go back to the list. All right, so Carolina, go ahead.
Which of the following statements regarding pulse oximetry is correct? Nope. I think D, the pulse oximeter is a valuable assessment tool that measures the percentage of red blood cells that contain hemoglobin molecules.
Nope. So what it actually does is it measures the percentage of hemoglobin saturated with oxygen, but it will not tell you the actual hemoglobin in the blood.
Oh, okay. So.
Okay.
I have a quick question about that one.
Yeah.
So is it true though that it says a patient with carbon monoxide poisoning, it can give you a false low reading? Because I heard that somewhere that was true. Just didn't know if it was.
Yeah, kind of, because like I said before, the carbon will bind to the hemoglobin as well.
Yeah.
Okay, so if there's more carbon dioxide, right, or the carbon monoxide, is it carbon monoxide or dioxide? Binds to the hemoglobin. Oh, got me looking things.
Yeah, because carbon dioxide.
Right, so the carbon monoxide will bind to the hemoglobin.
Yeah, okay.
Okay, as well. But
okay.
So the problem is that the carbon monoxide is a stronger bond than oxygen. Remember how I said like carbon dioxide, it comes in, the oxygen will just push it off. All right, when the carbon monoxide binds, the oxygen can't push it off. Okay, that's why you got to go into the bariatric chamber and have all that repressurized stuff.
Okay.
Okay, so
cool. Thank you.
It will give you a lower reading, but it shouldn't be a false low reading. It should tell you something's wrong.
Yeah.
So it's not necessarily what I would consider a falsely low reading.
Yeah.
It should just lead you to believe that, they're not getting as much oxygen as they should be.
Okay, thank you.
Okay, you're welcome. All right, so let's go. Get rid of that one. All right, now we're gonna do the cardio quiz. And then we'll get into neuro and GI stuff. Mostly neuro tonight. All right.
Which one is the other test?
Who is next? The other guy, Mr. Point Break. Go ahead.
Dissecting aortic aneurysm occurs when the inner layers of the aorta become separated.
No, I'm gonna go with no. You're gonna go with yes. I'm gonna say no though.
Well,
I believe that's the answer that it wants.
That's the answer that's in the book.
Yeah, but I don't. So the weakened area developed in the aortic wall is the actual aneurysm. The inner layers become separated. Is it a separation or a rupture though?
Jesus Christ.
Because I would have gone with the.
Yeah, I think it's just the difference between an aneurysm itself, which is just the weakened area developing in the wall, and then a dissection. A dissecting aortic aneurysm is what happens when it dissects in between the layers.
Right.
So,
But it doesn't necessarily rupture.
No, yeah,
Right.
yep. It doesn't necessarily rupture. Okay.
I think it's kind of like one of those subtle differences.
Dissecting aneurysm.
Right. It remains in the actual layers of the artery versus, yep. Okay.
And but it doesn't rupture.
All right. So we'll go with the inner layers of the aorta become separated. Sounds good to me. I would have given you credit for either one. All right.
We're wrong.
Welcome back.
All right. These people are going to hate me because there's going to be
is.
like 4 videos on YouTube.
The other
to watch
guy.
tomorrow. People are going to be like, what was he doing?
Just stitch them all together.
Stitch them all together. I don't feel like doing that much work.
Chapter 3 begin.
Fair enough.
Chapter 3 begins. Yeah, chapter 3. Here we go.
Chapter 3, part 1, 2, 3, 4.
Oh, see, but at least I'm at home and I wouldn't be angry and people wouldn't be seeing me want to throw stuff around the room.
The 4 of us sitting here in the elevator outside the classroom.
Yeah.
You guys are in the elevator?
Yeah,
all
we're
sitting
all
out-
in the elevator.
That's outstanding. All right.
I now know what seat I'm going to sit
Actually
in for the rest of the
standing.
class, though.
Now I know we're going to be for the rest of the class. Sweet.
You got to try these seats.
The elevator seats, are they nice?
I'll show you.
Okay.
Much nicer than the classroom.
He just insulted the classroom.
I mean, it is. Those chairs are horrible. I don't know.
horrible.
Okay, cool. We're all on the same page.
All right, Miss Addie, let's go ahead and do angina pectoris, please.
Okay, yeah. So I said it was D, I believe, mitochondrial oxygen demand exceeds supply.
Yes, ma'am.
That's what I thought.
Okay. Miss Bridget, let's do number 3.
Cardiogenic shock following an AMI is caused by decreased pumping force of the heart muscle.
Yep. All right, Miss Gianna.
I'm muted. I've been trying really hard to study because I'm just not good with the heart, but I'll try. Deoxygenated blood from the body returns to the left ventricle.
Nope. Left ventricle does what? It's the biggest, most muscular part of the heart. What does that do?
Pumps the blood to the body.
Right. Okay. So that's not coming from the body. What's the first part of the heart when it's coming back from the two vena cava and it's coming back from the body? Where does that first chamber it dumps into? It's got to be one of the top ones,
right?
right?
Ventricle, right?
No, it's got to be a top one, right? Because
the left,
right?
the left. No, it's not the left.
Nope. The left side is all oxygenated. The right side is all deoxygenated, right?
Yeah.
Okay.
Okay.
So
The right atrium?
The right atrium, right? Because that's the first one.
Okay.
It's the one on top. Okay, that's where everything comes back to. All right, and then the right ventricle pumps it to the lungs, so it gets blood, or so the blood gets oxygen, right? Then the oxygenated blood comes back to the left atrium, right? And it
Okay.
gets pumped out through the body through the left ventricle. All right.
Okay.
You guys are going to have to know, it's just going to be on the state test. They're going to ask you blood flow through the heart and blood flow through the body. It's just something you guys are going to have to memorize for your state test.
I will die.
It's I know Joe says, why do you have to know it? And you really don't, but like the state says you do. And that's what they tend to ask you all the time. So.
I'm literally buying a model of the heart off Amazon because I just cannot understand the heart to save my life.
Yeah, I mean, plus once you look at it, you have to realize that the right and left sides are actually backwards because you're looking like
That's what
at a cross
confuses
section of
me.
it. So
I'm
once you
dyslexic
get
as
that
it
out of
is.
your,
That makes
yeah,
it so much harder.
it should be easier then because you should automatically see it backwards.
On the floor is hard. That's how you remember that. Atrium, you enter atriums when you go into a building, right? So those are always going to be the first thing when you come into the hall.
Okay.
You go up by the right side. So when you're looking down, it's reversed because it's the chart. Just like it would be things that are working with water.
Yeah. Okay.
The answer was right atrium, correct?
I have to like do this.
Yes, the
almost,
answer is
and
right
then
atrium.
Reverse it.
So the easiest way that it took me to remember it is that if you look for the big meaty V, right? Like if you look at a picture of the heart and you see the big thick muscular wall and it forms that V, the big thick V is the left ventricle. All right, because that's the one that does the work. If you can remember that that is the left side, then you know, and that's the oxygenated one. That's the one that pumps everything to the blood. You can go backwards from there. Well, that's whatever works for everybody else. I saw Emily. Emily just left. She was next. All right, Miss Isabel, you're next then. Number 5.
Okay. So in contrast to the sympathetic nervous system, the parasympathetic nervous system slows the heart and respiratory rates, which would be B for you.
Yep, slows the heart and respiratory rates, right? So good job. All right, who's next? Joe? Joe's next. Number 6.
Be next. Joe, unmute. Oh crap, Joe can hardly read this. Most patients are instructed by their physician to take up to blank doses of nitroglycerin before calling EMS. I don't know.
You don't know. We went over nitro.
I know, but I don't know from before calling the EMS, like what the doctor tells them to do. 3 sticks out in my mind, but I don't know why.
Yeah, it's
3 might
always
be the
3.
count. All right.
It's always 3. That's why, like, when you guys are able to assist, you ask them how many they've taken, and you can assist up to 3, right?
Good job, brain.
It's always 3.
Okay.
Can you overdose on nitro?
Yes, yes, you can. You absolutely most 100% can. And can anybody tell me what the physical findings are going to be now that you've asked the question?
Your blood pressure would drop through the floor.
Yeah, so what is hypotension going to cause?
Shock.
Well, yeah, it'll look like shock, but yeah, hypotension is going to be one of the major ones, right? But
okay.
Yeah, no, your blood pressure goes through the floor. So I had a guy in Chatham, and the doctor told him when he had chest pain to take the nitro pill. So my friend apparently just decided to ignore the chest part of the order. So anytime he had any pain, he took nitro. And he used to always call being like weak and passed out, and his blood pressure was always like 40/20 because he had taken 4 nitros and not realized why the pain wasn't going away. And we kept yelling at him, and yeah, he wasn't listening. So, but yeah, so you can overdose on nitro very quickly, actually. Miss Joanna, let's do number 7.
Narrowing of the coronary arteries caused by buildup of fatty deposits is called atherosclerosis.
Atherosclerosis, yep. All right, everyone's favorite word that nobody can say right. All right, John, go ahead and do the next one.
Prior to attaching the AED to a cardiac arrest patient, the EMT should dry the chest if it is wet.
Yeah, yep. We don't put electricity through water, right? All right, who's after John? Julian.
The AED is most advantageous to the EMT because it does not require the presence of advanced life support personnel.
That's right. No. You're all right. It does not require ALS.
Oh.
All right. But it delivers prompt defibrillation to patients with ventricular fibrillation.
Okay.
So remember what we were talking about the other night is the sooner you defibrillate them, the better chance they have. Okay. It's all about early defibrillation. Okay. So yes, it does not require, but the most advantageous is defibrillation. Okay. All right, Kayla, let's get this one wrong.
The electrical impulse generated by the heart originates in the I want to say one of the nodes, but I don't think that's right.
No, so it is the node. All right, so the coronary sinus is a bundle of veins like on the posterior part of the heart. It has nothing to do with it. It's mentioned in one figure in your book, and literally has nothing in the book even is written about the coronary sinus, and that's what they say the answer.
That's what I was thinking it was.
It's not the coronary sinus. It is the SA node. Okay, the SA node is your pacemaker of your heart. All right, so the sinoatrial node. All right, it beats at 60 to 100 beats per minute. All right, when that one fails, it goes to the atrioventricular node. All right, that one beats at 60 to or 40 to 60. Okay, if this one fails, it'll go down to the bundle of His. All right, and the bundle of His is 20 to 40 beats per minute. Okay, and then if this one fails, then you're done. All right, I don't know why whoever wrote this question, I don't know what they were doing, but it's not the coronary sinus. All right, Lucy.
Sorry. 11, the iliac arteries immediately subdivide into the femoral arteries.
Right, yep. So where are your iliac arteries? Right. So where's the ilium or the ilius? Or where's the iliac crest?
hip,
Let's go that way,
right?
right? It's in the hip, yep.
Yeah.
Okay, so if it's coming from the hip,
Okay.
right, it has to go into the femoral arteries, okay?
Okay.
Because the tibial is your lower legs.
Yeah.
Right?
That just was where something divided. Okay, cool. Thank you.
Mm-hmm. All right, Luca.
The most common reason that many people experiencing AMI do not seek immediate medical attention is because they cannot afford it, do not trust EMTs, are elderly, are in denial. I have no idea, to be honest.
No. I'm gonna go with denial, but yeah.
Yeah.
That's what I thought.
If I had to guess, I would say denial. Most people,
Sure,
they don't want to know they're
are in
having a heart
denial.
attack, even though they have the chest pain. Right? Which I think is
No, they
stupid,
just
but
well, I think they're just like, oh, it can't be a heart attack. I'm fine. Like me, I'm not in shock. I'm fine. I can go home. That's gonna be like, oh no, you aren't.
well, I can't be having
Yeah.
students drop out on me. All right, Marissa, go ahead.
The right coronary artery supplies blood to the right ventricle and inferior wall of the left ventricle.
Yes. Right, because we talked about this the other day. Okay, so the RCA does the right side and a little bit of the back of the right ventricle, right? Because that's the workhorse. It has the most muscle. It needs the most perfusion, right? So the left artery and the right artery both supply it with blood. All right, Mark, 14. Excuse me.
Right. Upon arriving at the residence of a patient with possible cardiac problem, it's most important to stick with the basics and go assess the scene for potential hazards.
Yeah, this is a scene size up question. This is your basic patient assessment. They just want to know. You start at the top, right? This is Mr. Klein, right? Misha?
Number 15. When documenting a patient's description of his or her chest pain or discomfort, the EMT should use the patient's own words.
Yeah, use their words. All right. This is why I said don't lead them down the rabbit hole. Don't ask them what it feels like. Like, let them tell you so that way you know what type of chest pain you're dealing with, right? Phil?
When prepping to obtain a 12-lead ECG, the LL and the RL electrode should be placed on the thighs or ankles.
On the thighs or ankles, right? Yep. Taylor?
Which of the following blood vessels transports oxygenated blood? The pulmonary veins.
Yep. Yeah, this is that trick question, right? They give you, they just want to make sure that you know what's going on. All right, Point Break. No, Patrick took a break for a minute.
D, aspirin.
Which of the following medications is commonly given to patients with chest pain to prevent blood clots? Yep, aspirin. You're probably muted while you're reading the question.
What?
So you probably muted while you're reading the question.
Thought I had unmuted it. Sorry.
You're okay. You're fine. Carolina?
Which of the following signs is commonly observed in patients with right-sided heart failure? Is it the pulmonary? No, I'm sorry. No, I'm reading a question here. Right-sided. Hold on, we just went through this. Is it dependent edema? I'm thinking
Yeah.
fluid.
So the dependent edema means it's like outside, right? It's at somewhere out in the body. Okay. It could be in the hands, it could be in the feet, could be in the arms. All right, it's somewhere. Okay. So labored breathing, pulmonary edema, flat, that's all left-sided heart failure, right?
Yeah.
So good job. Addie.
My screen's really blurry. Can you read it?
Yeah, Lara was having that problem before. Which of the following statements regarding nitroglycerin is correct? The potency of nitro is increased when exposed to light. Nitro usually relieves anginal chest pain within 5 minutes.
That one, right?
A maximum of 5 doses. Yeah, it's within the 5 minutes.
Okay.
Right, we don't give nitro between the cheek and gum, and we don't give 5 doses unless we call med control and they say okay. All right, so good job. Anybody got any other questions for any of the 2 quizzes or any other questions in general?
Yeah.
Before we move into the other one. Anybody? No questions? All right, let's take 8 minutes, I guess. Come back at 7 o'clock and we'll jump into the neuro and the GI stuff.
No, we were taking because the system was down. Oh wait, hold on. Oops, didn't turn my microphone.
Oh, that's not what I want to do. This stuff over here. Can mean some serious things. All right, so we'll watch the video here first. Why is there no sound? Oh, you guys aren't getting any sound, right?
So at the top of the screen where it says you're viewing your screen, there was also a little mute like symbol next to it as well.
It says you are screen sharing and there was a mute.
Yeah, there was a mute symbol when you had the video up.
Okay, let's try that again. Your screen sharing. I don't see a mute symbol anywhere.
It's no longer there.
Okay. Pretty sure it probably has to do with my audio settings somewhere. Let me look real quick. What is, that's why, because Netflix. No, that should be right. This is on. All right, let's try this again. Nope, no sound. Why is there no sound? Oh, because this one's wrong. You know, I said here, had all this stuff set up, good to go.
Do you hear it in your headset?
Nope. Oh, it's because that's turned off now.
Mike, and on today's episode,
There we
are
go.
going to be continuing our nervous system series.
I have a feeling you're going to hear it through
in-depth
my
look at
headphones.
The central nervous system, more specifically the brain. While creating this video, I quickly realized
Stop it.
there was just too much information I wanted to share with you guys on the brain alone. So next week, we'll be concluding the central nervous system when we speak solely about the spinal cord. Last week, we talked about the basic building blocks of the human nervous system. So if you missed that video, click the eye above my head to check it out. With that being said, let's dive in and get started. The central nervous system consists of the brain and the spinal cord. We refer to these parts as central because they receive, interpret, and transmit all the messages to the body, controlling every action your body undergoes, from moving your arm to releasing hormones to control of vital signs. The brain is the most complex human organ. Comprised of over 33 billion neurons, the brain functions as your body's main control center. where approximately 20% of the body's blood and oxygen supply is utilized. This light but heavy 3-pound organ is protected by the meningeal layers within the human skull. Now, before we continue, make sure to answer the question of the day in the comments below. How many pairs of cranial nerves does the human body have? Anatomically speaking, we divide the brain into 2 hemispheres, the left and the right. They are joined by a bundle of fibers called the corpus callosum that transmits messages from one side to the other. The theory that we have a rational left brain and an intuitive artistic right side is literally nothing but nonsense. Humans use both hemispheres of their brain for all cognitive functions. Brain imaging studies show no evidence of the right hemisphere as the focus of creativity, and the brain recruits both left and right sides for both reading and math. The cerebellum is the largest part of the brain and separates the humans from the rest of animal kind. The cerebellum is where all of the human's higher function and thought processes are performed. It is divided into 4 lobes.
So he keeps saying cerebellum, he means cerebrum.
Emotions, personality, concentration and problem solving, even some speech and motor function. The occipital lobe, which interprets vision, colors, light, movement. The parietal lobe interprets language and sensory information, as well as some spatial and visual perception. Lastly, the temporal lobes organize memory and sequencing, interprets language, and also hearing. Deep within the brain, there are 2 structures that need mention. The thalamus serves as a relay station for almost all information that comes and goes to the cortex. It plays a role in pain sensation, attention, alertness, and memory. And the second is the hypothalamus, which is the master control for all autonomic systems. It plays a role in controlling behaviors such as hunger, thirst, sleep, sexual response, and it also regulates body temperature, blood pressure, emotions, and the secretion of most hormones. The cerebellum, also known as the little brain, is located in the back of the brain and is responsible for controlling balance, muscle coordination, and muscle movement. The last major brain structure is the brainstem. The brainstem is made up of 3 structures: the midbrain, the pons, and the medulla oblongata. All 3 regulate and control most autonomic bodily functions. The brainstem is the lowest portion of the brain and connects to the spinal cord through the foramen magnum, or the large hole in the base of the skull. The midbrain controls vision, hearing, motor control, sleep and wake cycles, arousal and alertness, and finally, temperature regulation. The pons controls arousal, respiratory processes, fine motor control, equilibrium, muscle tone, and the regulation of sleep. Lastly, the medulla oblongata controls many key functions of the autonomic nervous system, including respiration, cardiac function, vasodilation, and reflexes such as vomiting, coughing, sneezing, finally swallowing. Well, guys, that is a lot of information on the brain. Make sure to join us next week when we conclude the central nervous system with the spinal cord. In the meantime, stay safe out there, and I will see you guys in the next video.
All right, so who noticed something about the brain and the anatomy of the skull? Did I notice anything similar?
The different sections are named the same, kind of like our bones and arteries and everything match up.
Right, so the frontal lobe sits behind the frontal bone of the cranium, right? The occipital lobe sits behind the occipital bone, okay? So this way, you know, like if you know the bones, you know where the part of the hearts are, right? Or the parts of the brain are, okay? So here we have our spinal cord, all right? And it shows you the foramen magnum sitting just down right here, right? Green might not be the right color. Let's go with red. All right, so the foramen magnum sits right here, right? That's the big hole in the base of the brain. All right, the little cerebellum, which does all our balances, sits right there. Okay, spinal cord, what? Okay, spinal column comes all the way down. All the nerves that innervate branch off.
No.
Hello, Joe, what can I help you with?
My video left.
Your video left. That's not
I'm
good.
trying to find it.
Okay. Just make sure it doesn't run down the stairs on you.
It's in safe driving mode. I don't know how to get out of that.
Were you walking around? Why are you in safe
No,
driving mode?
I don't know why. I hit a button.
What did you do? Ask them. Ask your friends. You have friends there.
I hit a button.
I don't know
Figure it
anything
out.
about the iPhone. Maybe somebody can help you.
Carry on.
Okay. All right. So all of these nerves come through major plexus, right? And they all happen in major areas of the body. Okay. And this way, like we talked about in trauma, anytime an injury occurs at these sites, like we can tell based on how people are feeling, right? Usually we do this stuff first before we do trauma, but now it should all make sense. Okay. All right, so we have multiple different disorders of the brain. Okay. The brain is very sensitive. Like I said, it's the second most greedy organ in the body, right? The heart's number one. The brain is number two. Okay. The brain likes oxygen, sugar, and it likes to regulate temperatures. Okay. So that's why we always check someone's blood sugar when they're altered, right? Because we know that sugar actually makes a difference. We check to make sure they're not hypoxic, right? We check to make sure that they're not hypothermic or anything like that. Okay. So if the problem is caused by the heart and the lungs, right, the entire brain will be affected. Okay, because it's not going to get perfused and it's not going to be oxygenated properly. It's not going to get the nutrients it needs. If the problem occurs in the brain, only that part of the brain where the problem is occurring will be affected. Okay, so in general rules, like people who are hypoxic, their whole brain is going to show brain damage, right? People who have a stroke, all right, if they have a stroke in their occipital region, only that region is going to have deficits. Okay, they're not going to have a full brain infarction. Okay, so headaches. This is where we're going to talk about headaches are not really headaches. All right, everyone has a headache. We've all had them. We all have them all the time. Migraines are becoming more and more prevalent nowadays. Okay, so headaches can be a headache. It can be simple and benign, or headaches can be other rather serious neurologic conditions, such as a stroke, especially hemorrhagic strokes. Okay. Right. It says here only a small percentage, right? They're not, that's true. Okay. Most headaches are just headaches, along with other diagnosable things in the field and stuff that we look at. We can see when a headache isn't really a headache. Okay. So again, we have the three kinds. You have tension headaches, migraines, sinus headaches. I think are the worst because they feel like your eyeballs are about to shoot out your head. Right, but they're not life-threatening. These people take some Tylenol, take some ZQuil, go to bed. Right, it's not life-threatening. Okay, tension headaches are muscle contractions in the head and the neck. Right, usually stress headaches. All right, it's usually dull, squeezy, achy. All right, again, usually don't need medical attention. All right, most times headaches are, most people don't even call for headaches unless it's like the worst headache they've ever had in their entire life. Okay. Migraines are caused by changes in blood vessel size at the base of the brain. Okay. So the blood vessels are either dilating or constricting. They can be had by both adults and children. The pain is usually like a pounding, a throbbing, like a pulsing pain because of it's caused by blood vessels. So people be like, I can feel it throbbing, like my head's throbbing, or I can feel my pulse in my ear, stuff like that. And obviously there's usually some nausea, vomiting. Most people can't open their eyes, or they have severe visual changes or photosensitivity, right? And we know that these can last for a couple hours or a couple days. All right, sinus headaches are fluid accumulation in the sinus cavities right by the nose and under the eyeballs. Right, they have nasal congestions, cough. You may have a fever if it gets an infection. Okay, any of these three things we're really not doing anything about. Okay, we just want to know these types of headaches so that we can determine them from this type of headache. Okay, so serious headaches can show hemorrhagic strokes, brain tumors, or meningitis. All right, if they have a sudden onset, severe, thunderclap is the word that most people use. Any types of these types of headaches or head pain or anything like that, if they have photosensitivity that goes along with it, they can't open their eyes. Okay, they may not have the seizures yet. They may not be altered mental. Okay, but they might have that sudden onset headache. All right, that doesn't mean that they are having a hemorrhagic stroke. Okay, but it's our spidey senses should start tingling, right? That gut instinct should be like, this is probably not a normal headache, right? So if you do see seizures in a headache or altered mental status in a headache, then we're suspecting strokes and possible hemorrhagic strokes. Could be meningitis, right? If you see anything else indicative of that increasing ICP, like we talked about before, okay, or the head traumas, again, head trauma could be like a hemorrhagic stroke happening and they're caused by the trauma, right? But it's still considered a hemorrhagic stroke. All right, so these are the headaches that we're worried about. Okay, so strokes, also known as CVAs or cerebrovascular events. Okay, it's either a blood clot or some sort of interruption to blood flow to a part of the brain. Does not have to be in all of it.
Hello?
Yes. Hello. Can I help you? All right, so strokes, basically a CVA or a cerebrovascular accident. All right, was that me? I guess that failed again. Is everybody here? Can you hear me?
We can. We were muted. We're sorry.
No, that's fine. I just wanted to make sure Zoom was working again because apparently, things are gonna.
You were just in a galaxy for a second.
Yeah, I use that as my background when I have my video on. All right, let's try this again. I heard Joe say hello, and then all of a sudden, like everything stopped working.
I have that effect on people.
Yeah, you do sometimes. All right, so where was I? What was the last thing you guys heard?
That it was also called a CVA.
That it was also called a CVA. All right, so you didn't hear anything I said about stroke. Okay, so we have two types of strokes, right? What are the two types of strokes? Someone tell me.
Ischemic and hemorrhagic.
Right, so we've been talking about the hemorrhagic strokes, and that is basically when, due to a trauma or some sort of pressure or something happens and a blood vessel ruptures in the brain, right? And blood starts accumulating in between the blood tissues or brain tissues, right? It starts creating that intracranial pressure. It does not allow the brain to perfuse in those places, right? So, and then you start losing whatever function that happened in that area, right? So they can either be the headaches, they're going to have symptoms indicative of what lobe that they're actually causing a problem in. Okay, so they may not be your normal stroke-like symptoms. All right, your ischemic strokes, which is usually a blood clot or something of other kinds, is interrupting the perfusion to the brain, right? So again, you're going to lose that brain function in that area. Okay, you may, most oftentimes they're unconscious, unresponsive. They have that weakness in the right or left side. They may or may not have that facial droop, right? The indicative facial droop, the slurred speech, okay, depending. All right, but all of this is a lack of oxygen, right? This is why we have a certain amount of time. We have, again, it's like a golden hour, right, to get them onto TPA and, you know, further functions, surgical interventions, sorry. But basically the lack of oxygen in the brain cell, right, those cells begin to die. And brain is a lot like heart tissue. Once brain cells die, that's it. We don't get them back. Okay, so again, in the presence of a stroke, it's not a sit around and wait kind of scenario. Okay, we're going to diagnose the stroke, we're going to get them moving. All right, we're going to take care of them, and then we're going to get them out of there. All right, so this is why we have, depending on the type of stroke it is and where it is, all right, we do have, it used to be 4 hours. It's down to like 2 hours now. The sooner we can get it in, I think the better that they find, obviously, right? Because the more oxygen or the less lack of oxygen that these cells have, the better it is, right? So we need to get them into somewhere that has interventional radiology where they can go in and they can get these blood clots out of wherever they're at, or they can do whatever it is that they do for the hemorrhagics, okay? Whether it be the TPA, the blood clot busters, right? There's contraindications for all that stuff you guys don't need to worry about, but all right. So the ischemic stroke is your most common. All right, you're not really going to see a hemorrhagic all that often. Like I said, they usually come from a clot or an embolus or something. Okay, and you're going to see all sorts of symptoms. All right, atherosclerosis, arteriosclerosis, all that kind of stuff, all plays a factor in it. Right, if you've had, it could be someone in a nursing home who doesn't get up very often and they have DVTs, right, deep vein thrombosis. One breaks loose from the leg, makes its way up towards the brain, gets stuck. Right, could be anything. Okay, could be someone who has AFib and a blood clot starts in their heart, right, and then works its way out. Oh. So this is just showing what happens basically, you know, in the blood vessels. That clot happens, and then this part of the brain over here on the right hand side starts becoming affected, becoming hypoxic, right, and doesn't exactly perfuse and or work anymore. Okay, it can be a complete occlusion, it can be a partial occlusion. They don't always have to be full infarcts. All right, so the hemorrhagic stroke is the least likely one, right? We talked about it. It's bleeding inside the brain. Okay, these ones are usually not good because there's not much they can do. Hopefully, if it's not bleeding bad enough, the brain is able to reabsorb that blood and it cleans itself out with little to minimal deficits. Otherwise, these are usually like severe stroke patients, right, that end up in nursing homes or in a hospital bed in the house somewhere. Okay. High stress, high exertion, okay, super high blood pressures also, all right, tend to have these happen. They may have even had small aneurysms growing inside their brain, right, and then they might have ruptured. Okay, so who knows? All right, this is a nice little radiographic image. All right, this is interventional radiology. They send the wire up, right? They induce contrast dye so that they can see the blood flow, all the vasculature in here. All right, and then that's where they find the clot. Right, so this one's an aneurysm. Okay, this one's where it's bleeding out. All right, they colored it red. It wouldn't be red like this. They colored it so you could see it better. Okay, so again, this one is why we talk about headaches, right? Because this is where you're going to have that sudden onset thunderclap. Worst headache I've ever had in my entire life. Like, no idea why. Nothing helps it go away. All right. And then in younger people, it's usually caused by aneurysms, like we talked about. All right. So who can tell me what a TIA is?
That's a mini stroke, right?
Well, they're called mini strokes, but explain to me what a TIA is. Or what do you think a TIA is?
Is it like, oh, what were you gonna say?
It's a blockage or an occlusion that repairs itself.
Right. So it may be a blockage that repairs itself. Okay. It may be a smaller clot that gets lodged real quick that then comes out and goes somewhere else. Right. So usually they say up to 24 hours. I've had people who literally, like, they'll say they were stroking out in their house, and then by the time you get there, they're fine again. And like whether it was or wasn't a stroke or a TIA, like we always take them in, right? Because you're always going to say that you should get that CAT scan just to make sure, right? You're never going to leave them home, especially if there was some sort of involvement. Okay, so like I said, every TIA is an emergency, right? If they had if it's a true TIA, then they should know, because they may have a better, I'm not going to say a better stroke coming on down the line, but right, they might have an actual like larger stroke coming down the road, right? And of course, they should always be observed by a physician. So what are the 4 symptoms of a stroke, right? What's that FAST scale?
Droopage.
Facial drooping, right?
Slurred speech.
Slurred speech.
Headache.
Headache could be one of them. Yep.
Deficit to one side of the body or the other.
Right. That muscle deficit, right? From one side or the other. Okay. How do we test for that? What's our Cincinnati scale? How do we test
You
for a
have them
stroke?
like hold their arms in front of them, have them close their eyes, and then tell them to raise their arms, and then only one will go up.
Well, we don't tell them to raise their arms, right? We tell them to
squeeze our hands.
Right, we can do the squeeze their hands, but no, what are we looking for? What's the actual term of why we have them hold out their hands and see if one falls or not? All right, what's that called?
Ataxia.
Ataxia? No, that's balance. So what we're looking for is it's called pronator drift, right?
Oh,
and we're looking for, so you're gonna have them hold their hands, palm out. You're gonna have them close their eyes because you don't want them to see what they're doing. And you're gonna hold their arms, right? And then you're gonna let them go, and you're gonna say, hold your hands there. One should literally just fall to the floor, or should have they should not be able to keep it up, right? If they're having a stroke. Okay, we don't tell them to raise their arms, or we just try to have them keep them, hold them where they are. Okay, and squeeze my fingers are good. What else do we do? How are we gonna check for facial droop?
Ask them to smile.
Right, big old smile. Give me a smile. All right, one side should smile. One side is either going to droop or stay exactly the same, right? There's not going to be a difference. Okay, and then what else do we do?
Load and go.
Well, we do load and go, yep. But how do we test for speech?
Have them speak to us?
Right. And does anybody know? I mean, there's a couple whatchamacallit.
Mnemonic devices.
There's a couple sayings that we use, right? You have them repeat, you can't teach an old dog new tricks.
Oh yeah, okay.
Right. You can, my one partner used to love ask them if Mickey Mouse is a cat or a dog. Okay. Most people will freak out. Their brain doesn't comprehend because they're trying to figure out how to answer cat or dog. Right. And not say mouse. So there's a couple different ways that we can ascertain their status of where they're at, right? So if they also have sudden vision loss in one eye, right, like I said, or they're photosensitive, okay, if they have blurry or doubled vision, right, because that's going to be in that occipital lobe, all right, so it may be back there. Right, if they can't swallow or they're altered, they could be unresponsive, right, depending where it is. Again, those speech disorders, right, they might not be able to talk, they might have trouble talking, they might be slurring their speech, they might be doing stuff like that. So aphasia, so a lot of times people will try to talk, right, they want to be able to talk but they can't. Okay, that's called expressive aphasia. Like they understand you, they can follow commands, they can do everything you want them to do, and then when you try to have them answer a question, they're just like, they have no idea, right?
They can't articulate what they're trying to say.
Yeah, there's no articulation. Okay, then there's receptive aphasia, where you're trying to talk to them and they just don't understand anything you're saying. All right, so that ends up, they can have either version. Okay, they can be confused, they can be dizzy, all those other wonderful symptoms, the weakness. I've had some that are combative, again, because they don't know what's going on. They don't know what's happening to them. They don't know why you're there, right? Because they're not understanding what you're trying to tell them in order to help them. All right, so you really just got to be as empathetic as you can and compassionate as you can, and do the best you can with what you've got. Right, so here's another way that we can figure out what type of brain injury they're having. Okay, it's decorticate and decerebrate posturing. All right, so I'm gonna watch this video.
Hey guys, welcome back to another Something in About 5 Minutes, and today we are talking abnormal posturing. So let's get started. So guys, abnormal posturing here is really defined as an involuntary flexion or extension of the arms and legs, indicating severe brain injury. That is absolutely key for you guys to remember, okay? It occurs when one set of muscles become incapacitated while the opposing set is not, and an external stimulus such as pain causes the working set of the muscles to contract, okay? So as we move on here, just remember these three big key points, okay? It can occur as a response to painful stimuli, as well as it can actually occur on its own without painful stimuli, okay? Now, it's typically seen when herniation is occurring or is imminent. Now, remember that herniation is when there is so much pressure built up within the skull and brain cavity that the brain and the brainstem is literally getting squished out of the foramen magnum, or the large hole at the base of the skull. Okay, and that is what herniation is defined as, and that is typically when we are going to be seeing these posturing type events. Okay, and typically it occurs in two forms, and we're going to talk about both of these forms: decorticate and decerebrate. So decorticate posture is a sign of damage to the nerve pathway within the midbrain, okay? Remember, the midbrain is between the brain and the spinal cord. This is typically that brainstem area, okay? And we'll see it on the next slide, exactly where it is located on the brainstem. But remember, the midbrain controls motor function and motor movement, okay? And here it is located in this black circle. That is your midbrain. So it is at the top of your brain stem, typically you will see decorticate posturing earlier on because the pressure is hitting this midbrain first, okay? That's key. So some causes of decorticate posture, okay? Bleeding in the brain, literally from any cause. If it increases enough, you're going to get this decorticate posturing. Strokes, brain problems due to drugs and or poisonings, okay? TBIs, traumatic brain injuries, liver failure that eventually causes brain issues, okay? Increased pressure within the brain from any cause, okay? That's kind of an umbrella term or an umbrella category. Just remember, increased intracranial pressure will eventually, untreated and unfound, will, no matter what the cause, will eventually cause a herniation effect, okay? Brain or a brainstem tumor, okay? An infection such as Reyes syndrome, which you really have to be worried about more so in children than adults. All right, now, here's a picture literally showing you guys exactly what decorticate posturing or decorticate rigidity is, okay? So you're gonna have adducted, which means close to the body, arms. They're not gonna be out here, they're gonna be close to the body. They're gonna be flexed, so they're gonna be at a 90-degree angle, and they're gonna be coming up towards the body. The fists are gonna be clenched like this, and the fingers are gonna be to the sternum. And sometimes they'll even roll inwards, and the backs of your hands will be touching, okay? And it'll be like fists into your sternum, okay? Your legs, this can happen on one leg or both legs, and it really doesn't have, it's not like one side or the other. It could happen to either. But typically the leg is flexed, so it's nice and stiff and straight, but it will be internally rotated, okay? So the foot might point outward, but it's going to be internally rotated, all right? And these are the big signs that you're looking for. The thing that most providers are not to remember to decorticate is you're bringing your arms to the core. Decorticate to the core, okay? And that's typically how people remember decorticate. All right, guys, now let's get into decerebrate posturing. Decerebrate posturing is a sign of significant damage to the brainstem, typically below the level of the red nucleus within the midbrain. Remember, both of these posturings are happening to the brainstem within the midbrain. Here you can see where the actual level of the red nucleus is within the midbrain. Remember, with decorticate happens first. So here you're compressing the midbrain until you get to that level of the red nucleus. And then typically you will either start to see signs of decerebrate, or you'll start to see signs of decorticate and decerebrate posturing. Okay, so knowing where this is in relation to the start of the medulla and the pons is actually kind of handy, because you can kind of tell how far along the herniation is going. Now, some causes. You guys should have already seen these because the causes are literally identical. Anything that is going to ultimately cause herniation is going to cause decerebrate posturing. Okay, so I'm not going to go over these again. Now let's actually get into the nitty-gritty on what you're going to see when you see decerebrate posturing or decerebrate rigidity. Okay, so typically, again, this can happen on a painful response or can happen upon its own, but you typically will see a adducted, again, arms are close and they're rigid. They are flexed out, okay? And elbows are locked, okay? They are rotated inwards towards the core, and the hands are clenched but rotated outwards, as you see in this picture, okay? But then with your legs are also flexed downward, but your feet are going to be pointed straight outwards like the rest of your body. There's going to be no inward or outward rotation of your feet. It will be straight outwards. You might even see some clenched teeth during this posturing, and or some neck flexion where the neck actually comes up and bends to where you're almost like trying to roll onto the top of your head when you're laying on your back. So your shoulders kind of come up, your neck arches, and you kind of roll up onto the top of your head. All are things that you might see in the cerebral posturing. And remember, this can happen on one side of the body, both sides of the body, or it can happen without the legs, and it can just happen within the arms. So this is why knowing decerebrate and decorticate posturing is so critical. In ending here, I just want to leave with this. Remember that herniation is the name of the game. Herniation is going to cause a lot of significant issues with vital signs. So be ready for imminent cardiac arrest, cardiac dysrhythmias, and or respiratory depression and or arrest. So be prepared that your patient may have a bad outcome. Typically, a lot of patients that you see in this type of posturing will have bad outcomes ultimately when we get them to the hospital. When we're doing our motor response in our GCS scores, we typically are going to score for a normal adult a decorticate posturing of a number 3 and a decerebrate posturing of a number 2. So that'll help you out within your GCS score for motor function. So guys, that's it for today's video. Thank you for joining along. I know this was a little bit longer than our typically 5-minute videos, but it is very need to know information. So I hope you got something out of it. I will see you guys next Tuesday. Hey guys.
All right. So any questions on posturing?
When you transport, do you take any special precautions with that?
No, you're more than likely gonna either have to roll them into like a Reeves or put them on a blanket or sheet or something, and then you're gonna have to get them into the ambulance, probably posturing already. Like that's not something we can fix or solve or do anything, honestly.
It doesn't present like a seizure.
No, I mean, they might come in and out of it, but usually once they're postured, they're postured. That's like an Einstein, like whatever is going on has already caused enough damage that, the body is postured like that. All right, where is the thing that I wanted to show you? So I was trying to look up during the video one that I showed last year, and I don't see it, about the thrombus getting during why atrial fibrillation is a concern for people because of strokes, because you have things hiding in places that you don't really know that you have. So here's one of them. See if it'll let me. All right, can you guys see the screen? Does it have all the atrial images up there?
I see a slide.
You guys still see the slide? All right, let's go with this. How about now?
Now,
What do you guys see now?
bunch of pictures from.
Bunch of pictures. Okay. So this one right here. All right. And I wanted to get the one where it shows it beating. There's a video of it, but I can't find it. So this little thing right here is a thrombus that is growing in someone's left atrium. All right. So when the heart beats, right, this bounces all over the place. Okay. And the valves are here and here. All right. So this gets bounced back and forth. Now, if this gets out, right, this is going to go out and it's going to lodge somewhere. Okay. It's going to cause a whole bunch of problems for somebody, right? However,
So if it's in the left atrium, Dustin? Does that mean that it came from the lungs necessarily, or?
It could have come from the lungs. It could have grown right there in the left atrium.
If they had vegetation or something like that?
If they had something already there, right. So where's the other one that's in between? There was a picture of one. It was in between the two, and that's the one that really, because they're not always round little balls like that. Sometimes they are
Like spider webs and.
Sometimes they can be spider webs. Better. I just found it on my phone and now I can't find it over here. Like that's what I was trying to do, like on my thing, but it kept going back and forth and not letting me use my computer while you guys were watching the video. It was kind of annoying. All right. I'm not gonna worry about that. We'll go back. All right. So depending on where the stroke is, okay, left-sided or right-sided, right? If it's in left hemisphere, okay, back in the occipital area, right, you may have inability to understand speech, okay, and then those speech problems can be anything. All right. Now, the other way that you're going to notice what side of the brain is being affected, and not that it matters, right? It's not going to change our treatment at all. But left-sided strokes, you'll see all the symptoms on the right side of the body. Okay. And then the right-sided strokes, you'll see all the symptoms on the left side of the body. Okay. So you can almost pinpoint where the stroke is based on the symptoms that you're seeing. But again, for you guys, it's not going to change anything that we're doing, all right, to take care of these patients. Okay. So right-sided strokes, again, paralysis on the left side of the body. They will have surge speech. They may not even realize they're having a stroke. Okay. They may not feel any pain. Just, all right. When people are bleeding, all right, their high blood pressure, or especially if they have a history of hypertension, can be the bleeding. Okay. If their blood pressure is going up and keeps going up, right, that's a sign of that possible intracranial pressure. Okay. So we got to worry about that. If the blood pressure is going down, right, then they're going into shock. Okay. And then they're not able to do anything, right? They're not perfusing, their system shutting down, right? They could be decompensating, right? So we're going to keep, we're going to keep checking the blood pressures, all right, so that we know where our patients stand. All right. Are these 5 or 15 minutes?
5.
Right. These are 5 minutes, right? Every 5 minutes, every 3 minutes, as often as you feel comfortable doing it. Okay. Excuse me. So we also have a couple conditions that can mimic stroke, right? Hypoglycemia will have stroke-like state or stroke-like symptoms, right? You could be slurring your speech. You could be altered. You may have the weakness. It probably won't be on one or both sides, right? But some people come in and see someone and they freak out. All right. So we'll go back to my blanket statement of any altered mental status for any unknown reason, you should always be doing a blood sugar. Okay. It's just good to rule it out. And then that way you can move on and figure out something else, right? Because that's the easiest one we can fix. Okay. Start easy, work our way towards the hard stuff. Right. So postictal, sometimes if someone comes in after someone's had a seizure, all right, and they didn't actually see the seizure activity or know that this person may have a seizure history, all right, they might think the patient's having a stroke and they might call 911. So you might get in and you might see someone who is postictal. All right. So usually postictal can be anywhere between 5-30 minutes. I've seen it as low as 2, right? Depending on the person and what their recovery time is. They'll usually be labored in their breathing. There usually be some sort of snoring. All right. They'll always altered, confused, depending on where they're at in their restart process. Okay. And then subdural or epidermal hematomas, some sort of bleeding. Again, it's just going to cause that ICP, which is going to mimic a stroke. Okay, but it may not be as bad. I mean, it's bad. It's not a good thing, right? But then it's not a stroke. Okay, so again, you're not going to know without the CT, without the imaging, you know, if it's a subdural or a hemorrhagic stroke. So we're going to. So I think we're going to finish stroke and then we're going to be done for the night because I don't know why my computer's acting up. It's driving me crazy. All right. Does anybody know where we were? Where were we?
The last thing I remember is the subdural or epidural bleeding. That's the last note I have.
Okay. So we are on the fracture line, right? Conditions that mimic stroke. All right, let's go there. Let's go here. Let's do that. All right, can you guys see the?
Nope.
No, of course not.
Nada.
Nada. Why can't things just do what I want them to do? This is starting to get frustrating.
Starting
I'm trying to behave myself.
You get a gold star.
Yeah. Yeah, thanks.
Think about how much fun this is going to be for the people who are watching this after the fact.
Yeah, I don't even want to. Yeah, no. I'm gonna have to do what Phil said, and I'm actually gonna have to whatchamacallit,
There you go.
try to piece this all together with the
I say give it to them raw.
with the with the
Give it to 'em raw,
42
they'll be fine.
42 videos this is going to take. All right, so this is just showing you the subdural hematomas. All right, that usually will happen on a trauma line or a fracture line. All right, that those very outside blood vessels will break right in the middle of a trauma and may cause that pressure, that squeezing on the brain. Okay, so just, you know, in the face of trauma, be aware that it may not be a stroke. Okay, it may be something completely different. No, we're not going to do anything again. All right. So seizures, we talked about. Where are we at? Like I said, I might just. Seizures are what's that? Nope. I just want to see how far we are there. If we're about halfway, we can stop because we have an extra day to play with. We caught up last week or Monday. We caught up. Nope. We got to go a little bit farther. All right. Hopefully my computer doesn't shut down again. If it does, that's going to be the end of it. We give it one more try. All right. So if I disappear again randomly, then just take that as a sign class is over.
This is fun.
Yeah, this is getting fun. All right.
So much fun.
So much fun. Aren't you guys glad you got to go home for break? It's all your fault.
I'm sorry for being exposed.
No, that's not you. It is what it is. You're not the only one, sir. It's fine. All right, so seizures, okay. Basically, it is a surge of stimulus or electrical activity to the brain, okay? And the seizure is basically the brain's way of doing what my computer's been doing all night and restarting itself. All right, if something happens, it freaks out, and it's like, nope, nope, we're gonna turn off and we're gonna turn ourselves back on again, right? It's basically the body's reset button. Okay, so there can be convulsions, there can be non-convulsions. Sometimes it can be as simple as their eye will start staring up backwards, okay, and they'll have what's called an absent seizure. All right, so they come in many forms. All right, there's usually always some sort of altered level of consciousness plus the postictal state, okay? So we do have general and we have partial or focal seizures. All right. Again, it's either abnormal electrical discharges or an overflow of electrical impulses at once. All right. Again, yeah, I'm not really worried about the severe twitching. Okay. This is just kind of, oh, this is generalized seizures. Right. So the generalized seizures are going to be your grand mal's, like your twitching, stuff like that.
Do you think we heard any of that?
I don't know. Did you hear any of that?
Hey, Dustin, try giving your computer some Dilantin.
Dilantin? Yeah. So what was the last thing you heard then? Hello? Anybody? Anybody? All right, we're gonna go ahead and call it. For whatever reason, Zoom is not working. It keeps shutting itself off. Yes.
Try giving your computer some Dilantin.
I did hear that before I reset myself.
He just
So,
called it.
yeah, no, we're done. Everyone can go home.
We interrupt this
abrupt.
Zoom meeting for technical difficulties.
That's true. There's
Please
lots of
stand by.
technical difficulties. All right, we'll pick up
Did you
here
give your
on next
computer
week.
too much aspirin?
It might be hyperventilating. It might be. I'm gonna have to it seems like it's overheating, which I don't understand because it's on a bunch of fans. So I might have to take it apart and find out what's going on, but we're gonna hello, welcome back.
Too much aspirin?